Okay, so we're going to spend the rest of today doing a small group IRLM activity and then doing a little bit of report back about your experience doing IRLM. So you can do this individually if you would like to. The idea was to kind of do this at your tables as a small group, but I know you're like not really in like research teams probably at your tables, so totally fine to do this by yourself. To grab a partner, it is a little bit more fun to brainstorm with a partner or a small group. So that's what we'll do. Okay, I'm also going to talk. Actually, I'm not going to talk about this. That's tomorrow. I think I had they're not examples, but I had. Oh, I did have this. Okay, so I am talking about health equity very quickly. So I think I mentioned this already this morning, but just as a reiteration. So in the IRLM, we typically try to indicate the structural or systemic sources of health disparities, especially when you are explicitly trying to increase health equity or you are working with or including populations that experience health disparities within your study. Really just indicating those sources is the first step. And then, of course, we also try to select strategies that would address the root causes of those inequities, which really is those systemic and structural barriers. So some strategies might be needed for specific implementation contexts and sites, which I know dyed-in-the-wool hardcore clinical trialists are not going to love me saying this. But if I include, let's say, primary care sites at an academic medical center, and I include federally qualified health center primary care, and I do the same thing to try to support implementation, who do you think is going to be more successful? Okay, everyone got the right answer. I know you did. So the idea really is with equity, of course, we know those places are not starting at the same point. So they probably need different implementation strategies. Notice that I didn't say more. It's a fallacy to think that an under-resourced setting necessarily needs more implementation strategies or more implementation support. There are really good examples of LMICs who have almost no resources implementing fairly complex interventions because they're really efficient. Okay, so don't necessarily assume we just have to add more strategies or do more extravagant things. It may just be an issue of leveraging what you have a little bit more efficiently. And of course, there are outcomes that you want to indicate how you're going to actually show that health equity or reduction of health disparities has been achieved. My favorite one, again, is the representativeness dimension of both adoption and reach. So adoption would be clinicians and implementing sites. If I put out a call that says, hey, I want 12 sites who are willing to try to implement X intervention, and all I get is a bunch of high-resourced academic medical centers, yet it's an intervention appropriate for, or actually maybe even intended for, populations that experience disparities and live in low-income communities, I have a problem with representativeness right off the bat of who was willing to even adopt. Okay, and then of course we have who got reached. One thing I want to mention about reach, we have one study that is an HIV prevention study where we're using what's called a risk-adjusted reach rate, which is hard for me to say, which is why I have to think about it every time. So the idea in a reach-adjusted reach rate is that I don't get equal points for having reached a low-risk person compared to a person who's high risk. So in the case of HIV prevention, if I reach a cisgender white male who only has sex with, cisgender white women, that's not as good for the effectiveness or the overall potential impact of my intervention if I was able to reach an MSM who is Latino. Okay, they have a way higher potential of having a new HIV infection. So a risk-adjusted reach rate actually gives you more credit for reaching those people who are at higher risk. You could apply similar things to health equity too. So if you're trying to reach more of a health disparity population and individuals experience health disparities, you could potentially figure out ways to do an adjusted reach rate where you get more credit for reaching those folks. We also look at, everybody's interested in access, especially access to evidence-based care, evidence to healthcare in general. So your engagement and participation in the intervention itself can be an indicator of access. So we may actually be able to reach the hard to reach people or the people we're trying to get who experience health disparities. But if because of structural and systemic barriers, they can't participate in the intervention, they can't complete the intervention, they can't stay adherent to a medication, we're not actually really benefiting them. Okay, so the reach rate itself is one thing. We get people into the intervention, but then actually having completion rates is another piece. Oh, yeah. And then obviously the thing that almost all of us who are effectiveness researchers or efficacy researchers of interventions know, we need to show that we had relatively close intervention effects across all of our groups. That's another source of potential disparity. And I think actually our panelists had really good examples of, hey, if this intervention is not adapted for the community that you work in, it's probably not going to work, at least not to its fullest extent, right? So the intervention itself can actually be one of the sources of inequity, so we have to show that as well. I'm going to skip this. This is just our Circle Chicago Implementation Research Center, where we're focusing on hypertension control among African Americans living on Chicago's South Side, because they experience a huge disparity in both life expectancy and also all cardiovascular disease risk factors and outcomes. So in that particular project, this is what indicating health equity looks like within the implementation research logic model. And I got my cool pointer now. So you can see that here in the determinants level in our outer setting community, every single thing we're focusing on is a reason that there's health disparities in this community in cardiovascular health. Every one of these things is a potential structure or systemic barrier that we can try to address. In our recipient level, which is our faith-based organizations, community health centers, and the community, so the actual people living in the community, all of these are actually potential sources of health inequity as well. Okay, this is not always going to be the case, but this is a grant focused specifically on disparities elimination and working only with a population experiencing disparities. So this is not a larger study that includes, white folks who live in north side of Chicago. This is all south side Chicago. Over 90% is African American and Black. So when we actually look at our implementation strategies, here's the ones with the asterisk that we think are the ones that are most likely to actually reduce health disparities. And then we have our outcomes over here that I think, yes, sorry, it's just hard to see. So representativeness of both the adoption and reach are our two major indicators of at least health equity being, indicative within our implementation. And then, of course, we're actually going to be looking here at our BP control rate and guideline concordant hypertension diagnosis rate, making sure that that is not disproportionately or inequitably applied. So nothing really complex about this, but pretty important. Okay, so let's do our group activity. So we will have about 40 to 45 minutes to work on completing an implementation research logic model. You should have the quick reference guide and I think a set of the worksheets. Again, you will notice there is no strategy work no mechanism worksheet. So if you need help with mechanisms, raise your hand. I will be walking around. So here's your instructions. So to break into groups, like I said, it's more fun to work with a partner. You don't have to have three, but if two folks want to work together, pick one project of your own that you're working on. So an intervention that you are developing, an intervention that is moving towards implementation that you want to actually work through. Or I have two examples that were provided to you, I think, also on your table. One is implementation of an unhealthy alcohol use intervention in small primary care practices, which is an AHRQ funded study that I work on. And the other one is something in schools, I think. Right? eHealth HIV. That's right. I went with that one. So the other one is an eHealth HIV intervention delivered through community-based organizations. Okay. That's actually the study that I just mentioned had the risk-adjusted reach rate. So there's one of your outcomes right there. So populate as much of the IRLM as you're able to in about 40, 45 minutes. Indicate the relationship for at least two implementation strategies. And I mean the relationship being put your little superscript in and say for these two strategies, here's the determinants that it's related to, here's the outcome it's supposed to achieve, and propose at least one mechanism for each of those implementation strategies. And then if it's relevant, which it probably is for everybody, at least in some way, indicate any health equity relationships, kind of like you saw on the previous slide. So if you're not really focused on health equity, it may be only a couple little things. If you're more focused on health equity as one of your implementation outcomes, your aims, it might be a little bit more like what mine looks like. And we'll do a report back in the last like 15, 20 minutes that's really just going to talk about what was your experience doing this? What are some of the things that were challenging? Was there anything that you kind of learned going through this process? So I'll be walking around. I think I have one more quick thing. So this is a little teaser that at some point, very soon, we are actually going to have an interactive web-based tool for the logic model that is going to be housed on the HIV Implementation Science Coordination Initiative site. That is super cool. So be on the lookout for that. I will try to actually relay back to everybody here so that it gets distributed, but it's going to help you actually go through and create your logic model, mostly online. So yeah, really cool. Lots of kind of tutorial stuff built into that website. But for now, you get to just use some paper or a PDF or PowerPoint. So yeah, I'll leave the instructions up. And again, I'll be walking around to help anybody with any questions. Okay, we are down to our final 12 minutes of Thursday. That was mostly for me doing a mini mental status exam that I know where I am. So we're going to do like a very brief report back. Not every group has to report back, but I would love to hear people's just reactions to actually having to sit down and try to do this. Because me putting up the whole thing final doesn't show the hours of work and multiple people's perspectives who went into it. Now you get to see how the sausage gets made. So anybody want to share like what went well, what was difficult, what did you learn? Do you ever want to do this again, or do you hate me for even asking you to do it? It's okay if you hate me, it's fine. Okay. That's perfect. Reflections are good.
Was the temporality of the logic model of, identifying what things are in place now, what things will be part of our intervention, and what things are like in the future of like what could be. So it was just a challenge to think about in terms of, how do we determine these different sections? How do we like separate things out of, the culture as it is now versus the culture that will be in place once our intervention goes in place. And so it was just some conversations that we had of how to figure that out, annotate that.
Yeah, one of the challenges of a total hypothetical, for sure, too.
We looked at the unhealthy alcohol use intervention, and we really struggled. And then we got to that point of co-design. We thought, we needed to bring relevant people in. We need to bring in the patients. We need to have cabs, if you will, one for the patients, one for the primary care doc, and bring them in to then begin to co-design this logic model.
Yep, definitely. I would say that's a thing to do with every one of them. I like that as a recommendation.
So we really enjoyed the exercise. We did not fill out these boxes, but we enjoyed the exercise. And the reason why
you get an incomplete then.
Yes, but I'll tell you why we didn't fill out the box. As we started to, and then we realized there was some missing information. For example, the problem that was stated in the alcohol intervention started talking about state rates of alcohol use, but there was no evidence that this was a problem in that particular region where that small clinic was. And so we started to question what evidence do we have that this is actually a problem for this population in that area? And then we just came up with a lot more. What's the benchmark? If they're not been evaluating whether people have poor alcohol use, what evidence do they have? Is there some other medical reason to indicate that they're seeing adjacent medical issues that might be associated with? So we ended up asking more questions, which we thought was really great, because we write these little abstracts all the time, and you realize there's information I don't have. And then we were talking about that there are other people in here, for example, that we would need to figure out who are these other players. Is it IT? Is it biostats? And so we felt like to fill out this document, there was information that we needed to make sure that what we were saying wasn't just jumping to conclusions.
Yep, for sure. So that, again, artificiality of like the case study, but oftentimes we do have limited information about exactly what's going on. We either have to do formative work to find it, or we have to take best guesses too, right? So that actually is a real study, and that was the information we had. It was basically, here's the intervention you have to implement. AHRQ told us, here's the interventions you have to do. They said you have to do it in a place that has high rates of unhealthy alcohol use. They didn't say it had to be a clinic that had high rates. But of course, if population prevalence is very high, the assumption can be made, of course. But it's still a good point, and we probably should be looking at that. I think we actually have the data now, so maybe we should look at it. But also tricky, another thing you pointed out that does come up often in implementation research, especially when you're trying to do local context sort of needs evaluation. If they're not screening for the problem already, and one of your interventions is screening, you don't have a baseline. So you are stuck with, population prevalence, you're stuck with DUI arrests or DUI records and things like that in the county that it's involved in. You're kind of using proxy data, which is not always ideal, but when you only have a 3-month turnaround from when the RFA comes out, you do what you got to do to get the grant. So appreciate you pointing out actually all the necessary information you need to actually do this well. Because that came up actually in a number of places of like, I don't know for sure. So, do you have a comment? Oh, darn. I was wandering over towards Amy just thinking she had a comment. Perfect.
Well, it's going to be just a one-sentence comment. We talked a lot, and then we had a true moment of breakthrough, of insight from Dr. Maloney. She said, this takes more than 45 minutes.
Yes. So I did kind of jokingly say the hours that go into the logic model. The very first one that I showed you, which was the pediatric weight management intervention in federally qualified health centers, we completed that in the first 3 months of that project getting funded. This is an intervention that's gone through 4 trials, 4 large trials to get to this point. And we spent probably 8.5 to 9 hours in meetings that had 10 people in the meeting to actually get to that. So lots of time. And some things are low-hanging fruit. We're like, of course, it's going to be like a consideration of how much this thing costs. But a lot of the information, people went back to their FQHCs. People went to the literature to find what was going on. Yeah, a lot of stuff goes into this. So you can brainstorm and make stuff up. But Andy.
A question I've had throughout the day is that a lot of this, I feel like you've got Seifer for the left side, you've got Eric for the implementation strategies. The outcomes are pretty straightforward. The mechanisms is where where do you start with that?
Yeah.
Do you have suggestions? Because I don't think we got anywhere with mechanisms, and I feel like that seems like the most challenging part. How important are having mechanisms defined? Where should you, is there a place to start looking?
No, really good question. So again, we are going to build this out because it is a total deficiency. But to be honest, it was a deficiency in the field. So we looked, and there wasn't really an equivalent determinant framework or something for mechanisms. There still isn't, but there's now some better guidance. So the way that I always think about it, and this does not work for every mechanism, but I typically look at strategy, outcome, and clearly we have a black box in the middle that we're trying to figure out. Plug in the barriers. Take the barriers that you said were associated with that strategy and just ask yourself the question, how am I going to be modifying, changing, going around, going over, or going through this barrier using this strategy to get to that outcome? And usually that helps generate at least a couple of ideas. Not always, but essentially that really is the purpose of most strategies, is overcoming a determinant. So if you plug the determinant in and say, how do I have to change that? Then you can sometimes get to something.
That is actually totally spot on. I think that's one thing, if you're going to take anything from doing this, because I noticed in the mechanisms, you had the fewest number of references because it's like uncharted territory, but you're absolutely right. And within your determinants, you think about determinants you think are modifiable and which ones are not, or less modifiable. So, certain things like demographics, maybe not, but provider attitudes, behavior. And I think where we are really challenged is having enough good measures of the mechanisms, other than you probably can capture some of this through qualitative or mixed methods. What's your sense?
No, I totally agree with that. And to actually talk to one of Andy's other questions, do you need mechanisms? It depends. I think it's often a good exercise, period, to just go through like for your own thought process, how this thing is going to work, if it's going to or not. But the other one is it meaningful and important to measure the mechanism? Then it's obviously much more important. We have a grant that's going to get funded that the RFA explicitly says you have to test mechanism. So we didn't have an option. We had to figure it out, and we had to figure out mechanisms that were measurable, which was again another kind of a challenge to do, especially in a way that was going to be able to put it into an actual analytic model, because qualitative is hard to do in that.
Well, I was going to say at the very least, you probably want to do some PDSA cycles to know that your implementation strategy is working the way you think it will, which is your mechanism. And that means that you have some proxy measure of your mechanism.
Yeah, totally agree with that. We haven't used PDSAs specifically for like looking at mechanisms. But yeah, that would be actually a really good way to do it. The other reason I think with mechanisms that it's important to do is if you don't have the effect on the strategy that you think we're going to, it's really hard to understand what the problem is if you don't have a hypothesized mechanism at least, and can't just ask people like, hey, are you noticing that this is changing in your environment if you can't measure it? So that's another piece too, of just being able to kind of disentangle a little bit.
I think along the same lines of mechanisms and measurements, where do you generally see measurements in this framework? I feel very confused about I put them in 5 different boxes?
So measurement of what? Of everything?
I don't feel that necessarily measures of determinants make sense. But when we're discussing outcomes and mechanisms, even outcomes, I feel like I could sit down and think, yeah, all right, I'm going to measure this by saying, I got more physicians looking at this alcohol screening than I did previously. That went from a 5% rate of people who joined my class to a 30% rate. I increased my reach. I don't understand how that relates to mechanisms, even though I'm supposed to be measuring mechanisms.
I'm not sure I totally understand the question, but I'll speak to a couple pieces that you said. So with actual measurement, I typically try to operationalize the outcomes at least to say how I'm going to measure it or where the data is going to come from. So if I just put adoption in or like clinician adoption, it's usually not enough. So I would say like clinician adoption measured by EHR and maybe even the actual data field.
The metric.
The metric, right? So I'll try to operationalize it. So I'm not just like, I just don't want to say like just put re-aim in there because that wouldn't be enough, right? So I have to actually operationalize. For determinant measurement, I think that actually is kind of important. So in some of the work that we do, we've indicated which of these were actually measured as part of our preliminary work and which ones were from the literature or which ones were, just told to us by our stakeholders. So we are pretty open about how it was measured or where the data came from. But in terms of actually like layering on measurement in general, that's usually a separate document or a separate thing. So like you could do with your implementation strategies using lists or using the Proctor, the Powell and Macmillan. You just say that's what we're going to do and we're going to measure it this way, or here's the data metrics for that. But it usually doesn't go in there because it's so much detail.
Because I feel like the mechanisms box in particular is just like throwing me for a loop. Like I want to have measurements for those things, but I can't even like picture how to measure something like clinician training. I mean, I think the answer is I need to be more creative, but
possibly, but we just don't think about this that much, and there's not a lot of examples. So training is actually like probably one of the most common, and really our mechanism there is skill acquisition. Did you actually increase people's skills? An educational strategy is increasing knowledge. So those are the purposes of education and training. The other mechanisms that sometimes does, if you increase someone's skill, you increase their self-efficacy. If you educate them about the intervention and what it takes to deliver, you often increase the acceptability or perceived feasibility of that intervention too. Okay, because they know exactly what it's going to take to do it. So it's it does become kind of complex. And sometimes, not to make it more complex, sometimes there's actually multiple mechanisms that happen in its own sequence. So with the training example, you could increase people's skills. The increase in skill makes it more likely that they're going to view the thing as acceptable, and then more likely they're going to adopt it. And then the ultimate outcome is it reaches more people because they adopted it. So the causal path in some of these things gets really complex, but really for the mechanisms box, the main thing we're just trying to think about is what is the thing that's most important between the strategy and the desired outcome that we're trying to achieve. Maybe one
Thank
more
you.
comment, because I don't want to take us too long over time. You guys have all been awesome.
Oh, this should be the last one. I was just wondering, so I guess if we think about like mechanisms for implementation strategies, where strategies are also just a type of intervention, a lot of them are behavioral, right? So for example, with the training one, like if we think, oh, we're giving people more skills and that's why they're more, engaged, but it's really, well, we're just giving these providers a lot of attention and time or something, and that's why they're more engaged. That seems important because maybe you don't need to have super trained, implementer in every site. Maybe you just need to give people time and attention, which is what they've been asking for. So it feels like, it sounds like you said this 5 times, you guys are working on this, but it feels like that is really important because we're also investing all this time into the implementation strategies, and we're assuming that because we said, or we found evidence for XYZ in other contexts, like that's how it's working in this context. But sometimes that's the thing that we also have a barrier to get the implementation strategy in place, right? So it's like, sure, that's also a big investment. So that was just my...
Well, I think you're pointing out, maybe unwittingly, that this is why it's really important to figure out how to measure mechanisms, because you're right. It might not actually be about skill acquisition and you still achieve the outcome. So maybe training wasn't actually that important because the mechanism you thought it was trying to achieve was not actually what changed. So that helps you actually go back to the drawing board a little bit, or at least interpretation, right? You're not saying we did training to increase skill because we didn't increase skill. Yeah. Any very last burning comments? Okay, we'll see you tomorrow.